Hello, I'm Dr. Leonard Matheson.
I'm Dr. Kelly Deeker.
And I'm Dr. Matthew Dodson. Welcome to our introduction to forensic rehabilitation. This brief video will help you understand how we practice.
The origins of forensic rehabilitation are found at the Rancho Los Amigos National Rehabilitation Center in Downey, California. Rancho has been one of the world's premier rehabilitation centers for more than 80 years, originating the interdisciplinary approach to rehabilitation in the 1940s. A key component of this approach is the stage model of rehabilitation for acquired brain injury. We'd like to share that with you today. The 8 stages of this hierarchical model begin with the team addressing the person's pathology and diagnosis, getting a good handle on what's gone wrong. This is measured in terms of imaging, laboratory studies, or observed signs and reported symptoms.
The second stage focuses on the person's impairments, the loss or restriction of various person components, such as loss of a limb, paralysis due to a spinal cord injury or disease, or one or more problems with the brain, heart, or major other organs.
The third stage focuses on the person's functional limitations, or their ability to perform component actions and tasks.
The fourth stage of the model has to do with the person's occupational disability. We consider this broadly, looking at the vocational, societal, and familial consequences of the person's functional limitation.
The fifth stage of this model focuses on the person's vocational feasibility, their ability to perform fundamental work behaviors.
The sixth stage of the model is where we look at the person's employability. Building on their vocational feasibility, we now focus on the person's ability to become employed in the local labor market.
The seventh stage of the Rancho model has to do with the person's ability to perform a particular job, what is known as their vocational competence.
The eighth and final stage of the model addresses the person's earning capacity. At this point, we're concerned with the person's ability to earn income in work activities over their expected work life.
Now, the stages in the Rancho model are the same for all persons, no matter what types of problems they've encountered. What's different, and what we're going to talk about today, are the usual professionals who are involved on the interdisciplinary team.
Whenever we have a person who's had a brain injury due to stroke, concussion, skull fracture, or gunshot wound, really in any way, we pull together a team to provide services that address that person's particular needs. It's a different team from the team that's composed for people who've had a spinal cord injury or an amputation or some other serious illness or injury.
For people with acquired brain injury, the neuroradiologist is very important at stage 1, but that's where her participation usually ends. This contrasts with the neurologist, who is also in stage 1, but continues to be actively involved in evaluating impairment at stage 2. The neuropsychologist is also involved at stage 1, and the span of her engagement continues up through stage 3.
In this model, the occupational therapist and vocational evaluator have the greatest span. OTs are involved from stage 2 through stage 7. Vocational evaluators are involved from stage 3 through stage 8.
Now, one of the things you'll notice in this model is that it's hierarchical, moving up from stage 1 and eventually to stage 8. Each of the stages builds on the previous stages. In addition, each stage provides expectations about what the next stage can offer. In research terms, we describe this as the predictive validity of prior stages.
So, for example, the ability to predict impairment at stage 2 based upon what we know about pathology and diagnosis at stage 1, its predictive validity is quite strong, in the neighborhood of 70%. The ability to predict functional limitation at stage 3 based upon what we learned of the person's impairment at stage 2 is also pretty good, about 50%.
Problems develop when we try to predict across too broad a span. For example, predicting earning capacity based on the person's diagnosis is quite poor, in the neighborhood of 10%. Instead, if we predict earning capacity based on impairment, we improve our predictive validity to somewhere in the neighborhood of 20%.
We make a big improvement when we use information about the person's functional limitations to predict earning capacity, and improve predictive validity to about 40%. We start to experience a ceiling effect, but still make improvement in predicting earning capacity when we gather information about the person's occupational disability.
And you can see where this is going. Understanding the person's vocational feasibility helps us do a better job in predicting earning capacity. And of course, employability does a pretty good job of predicting earning capacity, but you'll notice that it's still not a perfect prediction.
Vocational competence improves that somewhat, but still falls short of a perfect prediction. We'll talk about that in other lessons. The closer we get to the stage and where we find earning capacity, the more powerful our predictive ability is. At that point, we call in a forensic economist to interpret our professional judgments and findings in terms of the person's projected lifetime earnings.
I described the Rancho stage model to the Social Security Administration and Congress in the early 1990s as a way to systematize the Social Security disability indemnity system. A few years later, they made money available for research to redesign the SSDI. At WashU, we developed a new method of disability determination based on the Rancho stage model. The first principle was that stage 3, functional limitation, was the crucial transition in any disability determination system. We recognized that this also applied to other models of disability in the United States, such as workers' compensation and long-term disability insurance, and both personal injury litigation and product liability litigation. We also attracted a lot of attention from other countries because management of work disability is an international problem for every industrialized country and every emerging economy.
The SSDI redesign project developed several important tools to help in disability determination. The Functional Assessment Constructs Taxonomy aggregated 131 constructs used throughout the world to evaluate disability. We collaborated to standardize the terminology. The FACT provides a brief definition of each of the 131 constructs and then organizes them into different systems and subsystems.
The project also developed a database of functional assessment measures to evaluate work disability. We gathered information on more than 4,200 tests and winnowed those down to 633 that were used to evaluate adults with work disability. We tied those to each of the FACT, the FACT constructs, and identified constructs that were well measured and those that had inadequate measurement.
So these are some of the foundations that we rely upon in forensic rehabilitation. We would like to demonstrate how this is helpful to determine the loss of earning capacity of a fictional client based on a real person, Peter. Peter is a 15-year-old boy with acquired brain injury and significant burns that he experienced in a tragic automobile accident. We'll begin our study of Peter by pointing out that vocational planning can begin at any age.
Vocational planning involves teachers. Vocational planning also involves parents. Vocational planning involves the person in their context, from the Texas Hill Country to the beaches of Southern California to the mountains of Appalachia. Vocational planning helps adapt the young person with a disability to his or her values, goals, and desires.
Vocational planning helps the professionals involved with a young person to choose and fashion equipment to optimize the young person's residual abilities. Without vocational planning, we leave the young person with tremendous anxiety about the future and all of the negative consequences that can accrue. Anxiety, depression, suicidality, and other self-destructive behaviors are much more likely if we don't assist young people to develop vocational plans.
This is because disability interferes with normal development. Adolescents are inherently uncomfortable with themselves. When you have a disability, the discomfort is greatly magnified. One of the concepts that's useful to consider as we look at this is core self-evaluation.
Research has consistently concluded that poor core self-evaluation leads to problems with adult development and affects a person's lifetime income. Core self-evaluation is the fundamental premise that a person has about themselves and their functioning and place in the world.
There's that word function again. If you're working in this field, don't ever stray too far from addressing your client's function. So let's take a look at Peter as a 15-year-old ninth grade student. He was injured at age 7, experiencing a significant brain injury and third-degree burns over large portions of his body. Due to his protracted rehabilitation, Peter fell behind at school. So at age 15, he's in the ninth grade.
Before going further, let's point out that Peter is luckier than most kids in that he has parents and teachers actively involved as committed members of our interdisciplinary rehabilitation team. The teachers focus on stages 3 through 5, but the parents are involved throughout and are crucial in vocational planning. Peter's folks are professionals. His father is a physical therapist, and his mother is a computer network architect.
One of the first pieces of our work with Peter is to examine how the functional limitations affect his vocational future. Now, there are two important issues we must face. The first is that Peter will have a differential trajectory to his earning ceiling than he would have prior to the injury. Now, the second is that he will have a lower earning ceiling in and of itself. Let's take a look at Peter's functional limitations with this thumbnail sketch. Peter has 15 functional limitations that we have rated on a scale from 1 to 4. This is based on the Functional Assessment Constructs taxonomy. 4 means that he has no functional capacity in this area, whereas 1 means that he has a slight functional limitation.
The constructs are provided by the fact, and the ratings are generated by us as we summarize Peter's records and evaluation results. In forensic rehab, these summaries help the people who are known as the triers of fact to be able to digest a tremendous amount of complex information so they can get a good picture of the person and arrive at a fair decision in a court of law. So Peter's hands and arms and one leg were severely burned, resulting in these functional limitations. As a consequence of Peter's brain injury, he has these functional limitations. And finally, due to the problems that the burns present, Peter has problems with both environmental hypersensitivity and personal presentation. His scars are unsightly, and parts of his body sunburn very easily, while other parts don't sweat, leading to problems with overheating when he is out of doors on a warm day.
Now, let's return to core self-evaluation and how it's affecting Peter. Remember that core self-evaluation determines how fully the person can use his or her resources. This hinges on the person's self-confidence. Peter has a hard time believing in himself. He's not totally disabled. He has a lot going for him, but he has a very difficult time giving himself credit. What makes this worse is that the visible disfigurement due to his burns are so difficult to get beyond. Virtually every new social encounter is a struggle for Peter.
So, how does this affect Peter in the long run? The research shows that kids with poor core self-evaluation are less capable of translating their performance in school to their earning capacity as adults. Notice that those with low core self-evaluation have an almost flat curve without regard to their success in school. People with a 2.0 grade point average make almost exactly the same as people with a 4.0 grade point average. Kids like Peter don't value themselves highly enough to have good career success. Second, young people who are able to develop self-confidence have huge differences in earnings.
So let's close this out by showing you what we do with our pre-vocational work capacity evaluation. We need to help Peter and his family plan for his future. We need to identify occupations that he should consider and what he will need to be successful. And finally, we need to take a look at how his success will affect his earning capacity. First, let's consider Peter's likely annual earnings. When we have two parents with established careers, all other things being equal, the simplest approach is to consider the average of their occupations as a reasonable pre-injury expectation. This isn't always the case, but it made sense with Peter.
His father is a physical therapist and his mother is a computer network architect. Here are the most recent earnings available from the United States Department of Labor for these occupational categories in the United States and in the Minneapolis-St. Paul, Minnesota area where Peter is growing up. Based on our evaluation, we identified physical therapy assistant as the optimal occupation for Peter. He has a natural interest in this area and an inclination to follow in his father's footsteps. So we laid out a program for him to transition from high school into a training program that would allow him to move at his own pace and with accommodations eventually achieve the occupation of physical therapy assistant. Here are the earnings in 2018 for this occupational category in the United States and Minneapolis-St. Paul area.
Another key part of the annual earnings differential is the trajectory of growth. Everyone who is successful in an occupation experiences increased earnings, but the slope of that trajectory of increase is usually not as good for people with disabilities as it is for people without disabilities. For Peter, we projected that he will enter the labor market at the 10th percentile and progress to the 25th percentile after 3 years. After another 4 years, he will hit his earnings ceiling at the median, or the 50th percentile. And here are the comparisons between the average of his parents' occupational categories and the ones that we expect Peter to attain. On this basis, we can make a year-by-year comparison of the differential between what Peter would likely have earned without his functional limitations and what he is likely to earn when he enters the labor market with those limitations. Now we can see for the first year in the labor market, that difference is $27,120. The next factor has to do with delay in labor market entry.
We already know that Peter has lost 1 year because the time out that he needed for rehab. With the cognitive functional limitations that he's experiencing, Peter is moving more slowly in school, even with appropriate accommodations and an active IEP program. The consensus is that his slower rate of matriculation can be expected to continue after he leaves high school in whatever occupational training program he pursues. We expect that he will enter the labor market at age 24. But we need to keep in mind that his parents' occupation typically requires 4 years to 7 years after high school. People going into the occupations of his parents usually enter at age 24 or 25.
The third factor to consider with loss of earning capacity has to do with what we call truncation of work-life expectancy. People with disabilities tend to be out of employment more often and for longer periods of time, and also leave the workforce earlier than people without disabilities. Based on a wide range of factors, we estimate this to be 15%. We expect that Peter will leave his career about 15% earlier than he would have without his functional limitations.
So, here's a summary of the data for Peter. We take his date of birth and injury onset, as well as anticipated retirement age and other data points to set the stage for a thumbnail sketch of our calculations. What we're about to show you is what we can provide attorneys or clients who want an estimate of the loss of earning capacity from an injury or illness. This is not normally what we would provide to the court, because a forensic economist has a more sophisticated approach. However, over the years, we have found that our estimates are reasonably close to what the forensic economists eventually present and are extremely useful in developing cases and future plans for young people and others.
So, starting at age 24, we can compare the average of his parents' occupational categories with the physical therapy assistant, both at the 10th percentile, which is entry level. The differential that we mentioned earlier provides an annual loss of $27,120 for his first year in the labor market.
But recall that there is also a different trajectory that Peter will experience in his growth of earnings compared to other people without disabilities. So as Peter matures, it takes more time for him to go to the next earnings level than it would have without his functional limitations. And at the 25th percentile, the earnings differential widens even more. This continues with the trajectory lengthening so that he would have hit the median at age 29 before he got hurt, but now he gets to the median at age 31. And the median is where Peter has his lifetime earnings ceiling. After that, earnings increase at the rate of total compensation for other civilian workers in the United States.
So now let's take a look at the end of Peter's work life. It may seem strange to think about this now, but it's critical. Because of the truncation of his work life, his last 6 years have zero income offset. So instead of working to age 67, Peter will conclude his work life at only age 61. This results in a lifetime loss of earning capacity of $4,454,890. Now keep in mind this is a rough estimate. We won't actually present this to a jury, but it can help the family or an attorney get a reasonably good rough estimate as they plan the way forward.
So that's it for our brief introduction to forensic rehabilitation. If you're an occupational therapist or a physical therapist or vocational evaluator, we'd like to help you continue to develop your career. Please consider subscribing, and we'll let you know when we have something new to offer. Take care now.